That brings up sort of a not so much a closing,
Yeah.
but an ending question of, you talked about how like the heroes, the main institutional
Right.
funders are now getting
Right.
behind this, that the public health agencies
Right.
are recognizing the value of this type
Right.
of collaborative network research. Is there any opposition? I mean, is there any, whether institutional or whether beyond even the health community, that are whether intransigent in terms of stuck in their old ways, or
No, I don't. Well, at this stage, I think we don't have enough of a profile, and we're too insignificant to have generated any opposition. So I think at this stage, there's just all kinds of feeling of, wow, this is a neat idea, let's move forward with it.
Mhm.
Hopefully there will be some opposition, because I think that becomes a measure of the fact that you're
That you're
having some
accomplishing
impact,
something.
and somebody
Yeah.
else, is going to be put out by that. So
Yeah.
that's quite okay.
Yeah.
I think one thing, though, that is also implicit in this, and this may be a place where there starts to become some opposition, is that it does mean a fundamental rethinking of the way we fund research. So right now, you fund individual projects, you ask for money in advance. It may take, a year, 2 years to actually go from the initial idea to having the money available to doing it.
Mhm.
And once that project's over, you have to get more money to either carry it on or to do something else.
Mhm.
This sort of model implies that the research is an intrinsic part of the process of clinical care,
Mhm.
and therefore the funding should come in Canada from the monies that support healthcare.
Mhm.
That some of that is going to go to maintain the infrastructure to be able to respond quickly. Not all of it, but that there is a core presence that has to be there to enable doctors to tweet about what they're seeing,
Mhm.
or
Mhm.
to have the structures that allow you to do it, to have the ongoing thought processes that say,
Well,
okay, this has emerged as the key question we have to answer
Mhm.
when the opportunity presents itself.
Well, and as powerful and appealing as an early warning system
Mhm.
is, it does require resources.
Right,
It,
absolutely.
it does require a support structure that allows you to be always monitoring, even in
Right.
times when it seems everything is normal and there
Yeah.
are no significant risks.
Yeah, exactly.
And I think you're right that if we carry this forward, the shift in the politics of funding, the shift
Mhm.
in the way that research is governed, which makes it more and more away from individuals and closer to a
Yeah.
common good,
Yes, exactly.
will
Exactly.
certainly displace others
Exactly.
that maybe
Yeah.
feel threatened by
Yeah,
that.
yeah. And I guess I think the two groups will feel threatened. Number one is nobody wants to spend more money on healthcare, although when you think of anything else we do, part of what you fund is research to
Mhm.
determine whether or not you're actually getting best value for the money you put into it. We don't do that in healthcare, and in essence, that's what we're talking about here. I guess the other group would be people who do things individually, but I don't think this supplants that. I think
Mhm.
it complements it, and there's always going to be a need for innovative, people who can really push a field forward, just as there's a need for being able to integrate what's going on and to use innovative methodologies to study what we do all the time.
Which speaks, really to the tension that's here, which is speed.
Yeah,
and
exactly,
the fact that
exactly.
these global pandemics have been occurring at a far greater speed than the institutions can respond. And part of this is to add that resilience, to add that
Exactly.
adaptability
Exactly.
to these institutions.
So I'm struck by the fact that we had a number of these groups had databases going, recruiting patients as early as the end of April during the H1N1 pandemic. First case was seen in March. By the end of April, we had databases accruing patients. By the middle of May, we actually had information available.
Mhm.
The WHO was still somewhat in the dark when they declared a level 6 pandemic in June, because what they knew was they now had data on 180 odd countries where there had been cases. But we could have really helped them in getting a sense as to how big or how little it is, because we had the data. But what we didn't have was the capacity to actually analyze that data until September, because we didn't have funding. It's all being done on a volunteer basis.
Mhm.
We're trying to figure out how do you put it all together, how do you get
And
data.
you're dealing with the day-to-day trauma of the ICU.
Exactly, and trying to convince somebody, please tell me what happened to this person who was in our database. We need to know if they lived or died, kind of thing.
Mm-hmm, mm-hmm.
But again, those are eminently solvable challenges, and so that's what I think is sort of neat about the prospect of bringing these different groups of people together to discuss how we're going to do it.
Great. Well, I think that's a great way to end. Is there anything else that you want to mention or talk about in terms of what you're looking to get out of the event and what you're hoping some of the outcomes would be?
I don't think so. I'll tell you what, I mean, there are several outcomes that we've identified. One is we want to coalesce this all into a sort of position paper that outlines a template for a model to respond to future pandemics, to set up the infrastructure. And that will include such things as open access, research protocols, open access consent form. The other thing that I've been thinking of just in the last week or two is the notion that these differing investigator-led research groups could get together now and design a protocol on severe respiratory infection that we would then try to seek funding for to implement around the world. So try to recruit an unprecedented number of subjects, maybe 15, 20,000 patients or more, to a study that the design would be every group does the study in their own jurisdiction, but they're all using the same protocol, but different interventions. So if in Canada, our question is, should we be giving statins and how much fluid should we be giving patients? Those would be the two interventions we'd study, and we'd set up a design that would allow us to do that. In Australia, they may say, well, look, we're interested in the statin question, but we think the more important question is antiviral treatment. In the United States, they may say, neither of those are important. We want to study these things. What we would then do is pool the data across all the different groups. And one of the beauties of that is if, suppose half the groups decided that the use of statins was the key question, you'd have more data on that, and you'd get an answer more quickly by pooling that across the different groups. So it's a very different model of collaborative clinical research, which I think there is the interest on the part of funders, at least from some of the preliminary discussions we've had, to think about funding. And certainly, I think there would be a lot of excitement on the part of these different research groups to actually say, let's see if we can do this. Let's do it both as a demonstration project and as an opportunity to answer very quickly some questions that we've all been struggling with for a period of time.
Well, and it's an interesting sort of model of globalization, where you're taking the sort of global view, but preserving the local context that allows them to get their own, whether it's regulatory or whether it's cultural, and that still have the access to all that data.
So it's very, very interesting, because we, as part of our project during the H1N1 pandemic, we tried to launch a clinical trial, and its initial goal was to answer a scientific question. If we gave a statin to patients, and there's good evidence that it might, would it improve outcomes? We very quickly realized that there were all these obstacles, and so our primary goal was shifted to actually understand what are the specific obstacles to undertaking research during a pandemic. And one of the things we learned is the whole question of indemnification. Huge thing when you go outside a country, that there are different standards and no mechanisms to cover legal responsibility. And that alone may mandate that rather than doing multi-center studies quickly, we're going to just have to do the same study locally, but a whole bunch of people doing the same study locally, and then agreeing to pull the data in.
And hence the importance of having that protocol, so that all that data can be essentially harmonized without having to deal with little inconsistency.
And having the structure and the goodwill and the collegiality to put all that information together at the end.
Although I think in concluding, it is that desire for impact that drives this, and the perception that that you can actually, instead of waiting years to find out how this can apply, can do that in months, if not even sooner in an emergency case.
Well,
it's encouraging.
The curious thing, as this is sort of evolving, is that one can plausibly argue that the questions that we would ask during the next pandemic, we can probably ask and more or less answer before it comes by looking at similar groups of patients and by setting up the infrastructure. So there may be some fairly highly specific questions. So for example, one of the potential places where this would be useful is during some other kind of global disaster. Suppose there was an earthquake and the optimal management of crush injuries, and how do you maximize survival in, say, Chile versus Haiti. We could do that, or radiation poisoning. And these are all things that we're faced with from time to time. So we could maybe set up protocols that can answer those. But a lot of the more generic questions, if it's an infection, we know the things we think might help in an infection. And it doesn't really matter whether it's SARS, whether it's H1N1, or whether it's seasonal influenza and community acquired pneumonia. We can actually test those now moving forward.
And part of it is the communications that exist.
Exactly.
That allows the front line to extend all the way to the policymaker, all the way to the public.
98%.
So that everyone is able to deal with whatever comes up.
Exactly. 98% plus of it, plus is the communications. I think the capacity, both being able to gather the information in the first place, to process it, and then to actually get it out so it's making a difference in terms of policy and care.
Well, this has been a great discussion. I'm really looking forward to the event because I think this model of network collaborative research is incredibly catalytic, and that once people start to realize what's possible, it'll scale, not just in medical research, but across research as a whole.
That's exactly right, because I think for all of us, it's an idea that had some abstract appeal and traction, but then you start talking about it, and you realize, wow, this is really transformative.
Well, and what's different, I think, from, you were describing that for your generation, the framework is there. As a culture, you were open to this stuff, but the social structure wasn't there.
That's right.
The tools weren't there.
Yeah, exactly.
And now we kind of have both.
Yeah.
So it's an exciting time to say, okay, let's see what we can accomplish.
Exactly right.
Right on. Thank you very much.